So I think for our audience, it would be important to mention what we mean inpatient or outpatient is that typically the CAD product, Axicel, from the ZUMA-1 data, is inpatient. When we try to do it commercially, because of Medicare also reimbursement, there's some issues, but typically they have fevers within 24, 48 hours. So that makes it difficult to obviously do it as an outpatient. The Kymriah is a little bit delayed, so it's sometimes a little bit easier, and then a lower fraction of patients that get admitted. But what is impressive is that although the toxicity is somewhat dramatic and it is manageable, and the neurotoxicity is reversible, patient recover. I remember a patient that I was on call a few months ago, a patient on a Friday night was on day 4 or 5 of Axicel and then had extensive disease, came from Carolina, and had fever that was expected, right? And then the next day she was intubated and obviously in the ICU, and it lasted 24 hours. Obviously she had some steroids because of toxicity, and she recovered, and she has been at least 6 months now out. So we see some amazing response. What we are missing, I think, in the CAR T cell is that we are obviously the next 3rd and 4th generation of CAR T and other therapies we'll talk in a minute, but is also having good biomarkers and identify who's going to have the clinical benefit. Because we know, and I think we should touch upon this, is that it is so exciting and generates a lot of interest in physician providers and patients and their families. But when patients fail CAR T cell, the situation is very difficult, right? So I think we should, before we go into the next generation of CAR T, how to overcome that, how do we manage a patient who failed CAR T cell? Peter.
Yeah, so the question was partially addressed last year at ASH when we saw a presentation looking at outcomes post-CAR T cells, suggesting, as you'd expect, that if somebody does not respond to a very good therapy, that they typically have a kind of lymphoma that is now not likely to do very well with standard chemotherapy or simple CAR T cells. There have been reports of people having responses to additional doses of CAR T cells in some clinical trials. There have been reports of people having responses to some chemotherapy, granted short duration. I think we'll talk a little bit later about bispecific antibodies, which I think have potential promise. In general, at our institution, that's been our bias, is to look for bispecific antibody clinical trials when we've had them available or elsewhere, because I feel that that may
So far, this has been the only really therapy that has improved somewhat some patient with some durability.
Right, there were
maybe as a bridge, yeah.
There was originally some thought that the immune checkpoint inhibitors might have the ability to sort of pull some people back. In my anecdotal experience, I have not been particularly impressed with that strategy.
So we had a handful of patients that relapsed and did well and then relapsed 3 months later and had rapidly growing mass. So 2 or 3 patients, we gave them low dose radiation for the abscopal effect with the checkpoint inhibitor. 2 or 3 of them have been in sustained remission. I think this is really interesting, but the checkpoint inhibitor seems very logical because we know that the PD-1, PD-L1 matters enormously in that setting. But we don't have a lot of great data. There's trials that are ongoing. There was a ZUMA-6 that was looking at combination with an anti-PD-L1 at atezolizumab, and then showing that you have probably a little bit of higher amplification of durability of the CAR T. But I agree with you, there's an opportunity, and I think the data that is the most impressive in prediction that is ASH already presented before is the day 28 MRD negative, CL3 DNA negative. It's very impressive. The patient, even with not great response clinically, do really well. So I think the opportunity to do something there. Let's talk about what's the next step in CAR T and how we can improve on CAR T. So there's, I heard 7,500 trials on cell therapy in the US alone. So I don't know how many globally, worldwide, but that's definitely a field that has a momentum. There's third and fourth generation, including double co-stimulator molecule, other construct, dual CAR and all that. So what do you think is promising, Greg, in that field?
I think if you look at this, the field really moves towards 2 directions. One is to add something to the existing products, and this will be PD-1 antibodies. People are also studying IMiDs and other targeted therapies in this setting, and there's a good rationale to combine it, and we'll see what's going to happen to those. The other compound which you could add to CAR T-cell therapies are bispecific antibodies, kind of upfront when they are being used. You have to be careful about toxicity there, but if you think about it, the theory behind it is very appealing, particularly if the bispecific antibody targets CD3 and CD20, which is not a target of approved CAR T-cells.
That would make it an easier dual CAR T.
Exactly, so it kind of brings the CAR T-cells and links it even more
Sure.
to the tumor cells. So those strategies are looking extremely attractive, and I think we'll be watching those very closely. And as you mentioned, modifying the product itself, having 2 targets is definitely very appealing as well, because we know that some of the patients who relapse particularly late after CAR T cells may actually be CD19 negative, and it's one of the mechanisms of escape. For some of the patients with early relapses, though, the CAR T CD19 appears to be still present on the cells. So those are the candidates which might be working on existing CAR T cell clone would enhance this therapy rather than looking for additional targets.
So when you look at the durability of response, and when we talk to patients, you talk to physician referring patient, they ask how we predict, and obviously we don't have a good ways, but and they ask the question that do we need a CAR T that persists over time? And then I know there's a lot of discussion about this, it's controversial or debated, but I am not a believer that we need to necessarily have the CAR T detectable for long response. We have about 30% of patients on Zoom one that had long response and didn't have any detectable CAR T. I really believe that what matters is the early amplification, and that's what really does the trick.
I probably agree with you, but I'll tell you for sure in 5 years.
Here we go. Nathan, what do you think?
So, it's interesting. We've also seen some studies, I think this was presented last year, that looked at the expansion of the rate of expansion, and it looks like patients that had a rapid expansion, although they achieved remission, some of those patients more likely to relapse early. And that was also correlated with bulk. So it looked like, again, whether this is a correlation or causal is unknown, but the patients with bulky disease expanded rapidly, but then the thought is that they develop T-cell exhaustion. Those are the patients that progress. Makes you wonder if maybe, these, and I looked at that early steroid data, and it looked like some of the responses, again, this is extrapolating, it looked better than what we had seen. Actually, the response rate was extremely high. I want to say the durable CR rate was like in the 50s, and you wonder maybe what they're doing is slowing expansion down a little bit and maybe helping some of these CAR T cells, I don't want to say persist long term.
Take a deep breath for the lymphocyte.
Yeah, take a deep breath and maybe not get quite as exhausted. I totally agree with you that I think that unlike maybe some of the acute leukemic trials, the first 3 months is essential. And we've seen that again and again, that it really, the patients that are achieving early CRs and CRs that are especially still there at 6 months are the ones that do well. You don't see anybody that eventually gets into remission at 12 months. It's either going to happen early or it's not going to happen at all in most of these patients.